This is the final session in the 5-webinar series sponsored by SA Health, and we're very grateful and would like to acknowledge that they funded this series. And this particular webinar will be focusing on nurse clinics, prevention in practice. So on the screen in front of you now are the learning objectives for today's session, and I'll just give everyone a moment to have a read of those. Okay, terrific, and I'd now like to introduce you all to Ros Rolleston. Ros is a primary healthcare nurse and educator from Nowra in New South Wales. She has a wealth of experience in both the acute and the primary care sectors and has almost completed a Master of Nursing. Earlier this year, Ros began a new role as the Skip Into Life Project Manager at Warragee Medical Centre. Skip Into Life is a preventive clinic for people with mental illness, and you'll hear more about this clinic during today's webinar. So welcome, Ros.
Thank you, Katie, and hi to everyone. Thanks for giving up your lunch break. So just to remind everybody that around chronic illness, it develops from prolonged exposure to risk factors. This means that we have many years where we can help and work with people to prevent the onset or at least delay that. Interestingly, 97% of Australian adults report at least one risk factor for a chronic illness, and 44% of Australians have 3 or more risk factors. So this is really important information that we need to base our preventative work on. Also important for us to always have in the back of our mind the groups that are at higher risk are the Indigenous Australians, people living with mental illness, people living with socio-economic disadvantage, those that live in outer regional areas or remote locations, and culturally and linguistically diverse Australians. So because they're at higher risk, the onset of chronic illness can be 20 years earlier. So people say, for instance, Indigenous or people with mental illness, we really need to be looking at them when they're in their 20s on how we can educate and work with them to prevent the illnesses coming on. Thanks, Katie. Few of the risk factors, just again to remind us, and we all know these I'm sure, but you know, it's genetic. If it's in your genes and you've got that family history, in general practice we're really good at keeping up with family histories and looking at people, helping them to prevent and delay the illness. Also age. We all know that we've got the ageing population, and as we age there's more likelihood of chronic illness. Gender as well plays a part here, as we've already spoken about Aboriginality and ethnicity as well. And then we've got the modifiable risk factors on our next slide. And it's interesting, we all talk about the tobacco and the excess alcohol, but maybe we're not as much talking about the inadequate fruit and vegetable intake. What about physical inactivity? Excessive sun exposure. This is really important for us in Australia, and I challenge everybody that is listening in today for what are the 6 S's of sun protection. So there's 6, so it'd be interesting to see what people can come up with. And also insufficient vaccination. We're getting better with our vaccination, and because of the no play, no pay, but there are still groups in our communities who have insufficient vaccination and unprotected sexual activity. It's a really important one for us to think about that as well. Thanks, Katie. So the enablers of prevention is over here on our patient side. I'd love to bring this chap in for a 45-year-old health assessment. It'd be an enjoyable, pleasant experience, wouldn't it? But for patients, the important things are reminders. if there is, if reminders are sent to patients, whether it's written, SMS or email, that actually prompts patients and it makes them think about it and brings them in. And the other enabler, importantly for patients, is the consistency of the information. So they come and see the nurse and they want the nurse to say the same thing that the doctor says, that the dietitian says, and that the information flows on to everybody. So it's really important that in our clinics we are actually collaborating with the nurses and the GPs and our allied health providers so that we are all on the same page. Here, over here with our GP clinician with a big smile on her face, and that's because at the clinical meetings we've got the evidence, we've looked at the current research, we've got the evidence around where it is that we do well and not maybe so well, and what is the latest information around prevention of chronic illnesses. The other thing that we like when we're as clinicians is that the consults are focused for prevention. We often do that quick little thing, you know, maybe around smoking cessation and spend a few minutes chatting about it. But where we feel we do our best work is if the consult is focused. That means it's been made specifically as a preventative consultation. So in the middle here, the research is really interesting because it shows us here both the patient and the clinician feel a therapeutic relationship improves the quality of preventive health care. Both the patient and the clinician think the family history is important. Both, as you would, think about, it's for the patient it needs to be affordable, and for us in the GP practice we need to actually be funded for this work. And then both groups as well, like general practice nurses. Patients like to see the nurse because they feel they're being more cared for and not taking up the busy GP's time with what they think is trivial stuff. And of course the GPs like the general practice nurses because we are uncovering all that hidden behind the scenes information and we're able to focus the consult, the time with the GP. Thanks, Katie. Then our barriers to prevention, and they're often just the opposite of what we've looked at. So in patients, the barriers, of course, socio-economic burden. That is that, the health literacy in this group is low. They don't feel they can always afford to go to see the doctor or get prescriptions. Their perception of the health risk is low. They don't see and think about whether they're smoking and not eating vegetables and that can lead to lung and bowel cancer. We said the low health literacy, but this lack of follow-up services is a really important one. From our patients' point of view, they really want us to see them more, not just one appointment for preventive, but they want to come back and so that we can keep them motivated. So organising the follow-up care is important, and of course cost of services is important for patients. Over on the clinician side, very similar kind of profile here, isn't it? It's the lack of time. We're all very, very busy and it's difficult to sit down and spend, extended time with people to talk about prevention of chronic illness. We have that acute care focus. But very interesting, I found this actually fascinating, that really the quality of the preventive information that we provide is dependent on our own personal values and beliefs. And so if we have a belief that nutrition is important, we're more likely to talk about it. But yet if we only think that smoking, or if we think alcohol is really the only issue, we'll only talk about those briefly. So again, it's still here with the lack of referrals as well, the lack of pathways. What do we do when we do a 45-year-old health assessment and find somebody with a BMI over 30 and, inadequate nutrition? Where do we go? How do we get that sorted out? We don't have those referral pathways always, only maybe in some rural areas. And again, for us, it's inadequate funding. So you can see that they kind of mirror each other, enablers and barriers. Thanks, Katie. And this is, it's a little bit complex looking, but it's really just looking at the Medicare Health Assessment Report. This was for the financial year 2015 and 16 in South Australia, and it's represented in this graph as a per capita per 100,000 and the percentage of overall of that item number. So we can just look at the first column, 701, and we can see that it's the turquoisey green that's got the most. And indeed, if we follow across through to the 707, it's an increasing number of the turquoise green, which is the over 75. And we know, even research, we've got the evidence that tells us that we're very good at this assessment. It's been around the longest. And we often go into the home to do that. So that's why we end up with a lot more 707s, which is the hour health assessment. We come back over to the left and we can see the group that are 55 to 74, there's only a small proportion here of assessments, and as you know, we don't actually have a standard assessment for that age group. So these would be people, adults with intellectual disabilities and people that are refugees coming into the country. And the opposite is true here. You can see now that the actual number, the percentage drops off for the longer consultation. And the same is happening with the blue, which is our 45 to 54. That's the age group, the 45 to 49 that we should target. The yellow is the 35 to 44. So that's our Oz risk assessment in there as well. Not a lot of sorry about the phone, guys. Not a lot of 15 to 34s going on, and we can see as well that our 4-year-old health assessment's dropping off as well. It's a shame that we've lost that one. But this final column over here on the right, I really want to drive this message home. So this is our 715. So this is our Indigenous health assessment. And you can see through the bright green, pink, yellow and up to the blue that that's all of those, that's 80%. 80% of the 715s billed in South Australia were for the age groups from 0 all the way up there to 54, and that's really good. The highest being the 0 to 14, followed by 15 to 34. So congratulations, South Australia. You're doing a great job here on your Indigenous health assessments and getting to them 20 years earlier than the non-Indigenous population. Thanks, Katie. Lovely little photo of a beach that's about 10 minutes away from where I'm sitting, and the beautiful sunrise at Culburra Beach. I just wanted to share the gorgeous landscape with you. Thanks, Katie. So I think it's important here when we're talking about prevention of chronic illness, as much as when we're managing chronic illnesses, that it is really a person-centred model that we're looking for. A lot of people talk about patient-centred care, but patient-centred care is really still giving the person that role of being the good patient that does what the doctor says, and it gives the health clinician that role of telling the person what to do. Whereas the key in person-centred care is that we're actually sharing in decisions. We're encouraging them to be a part of it. So we can see that outside circles that we need to be providing holistic care. So we're not just looking at an illness, we're looking at the whole person. We need to have a sympathetic presence. We need to be sharing in the decision making. We need to ask people how they feel about the choices that they're making and how they feel about the advice we're giving. And we need to have engagement. Engagement is all about listening to a person. It's all about them asking questions and being able to address that information at the level that the person can understand. And it's also working with the person's beliefs and values. And this can be a real tricky one for us in general practice when we're really busy, but it's certainly able to be placed into the extended consultations, and it's really about listening and uncovering what the needs are and working out what influences a person so that we can design our advice and strategies for that individual person and give them a higher chance of actually making the difference. And if we can achieve all of this, then we do end up with satisfaction with care. We have the person being involved in their care, their feeling of well-being. They feel nurtured, they feel cared for, and they feel valued. And we create that therapeutic culture. Thanks, Katie. Therapeutic relationships, just touching here about the important parts, because it is really continuity of care. And sometimes we find, particularly in larger practices or areas where there's high socioeconomic burden, patients might move around practices or just different doctors all the time. And if we're not having continuity of care, we can't develop a therapeutic relationship, and therefore we'll fail in trying to implement person-centred care. So it's all that continuity is about developing trust. That's where the person themselves trust and respect, you know, what the doctor and what the nurse is saying, because we're showing that we're respecting them as well. So it's also about improving health literacy, facilitating an agreed plan of action. That's the shared decision here. This is where we ask people about what they think could be a good solution. How could they, you know, input into what we need to change. And it's also about, as we've said, ongoing follow-up as well. Patients like to come back and see us for us to continue their keeping their motivation and their trust going. Thanks, Katie. So inclusive communication, this is a really important part of prevention and person-centred care. We need strong collaborative relationships between the GP and the GP nurse. Really important that we're not just in our own separate consult rooms, but we're working and talking together. Arrange for no interruptions when you're in a consultation. There's nothing more frustrating than the phone ringing when you're in a deep conversation and making progress with helping somebody. And it's also about uncovering their needs through engagement and discovering what is influencing them. Sometimes it's really interesting that it's their home life that is preventing them from making changes or achieving the goals that they want. And if we're not listening for this information, then we're not going to be able to make a progressive plan of action. We also educate people, and we need to educate them on their role as shared decision makers so that we can empower them with the knowledge that they need to enable them to implement the change. Rather than us doing that, we're telling you what to do. Thanks, Katie. This is just to remind us how really important and complex it is around prevention. It is more than just diet. It is more than just some protection and activity. We're looking at cardiovascular risk. We're looking at diabetes risk. We're looking to see how the kidneys are working. Is there, you know, ways that we can protect them? What about respiratory? What about sexual health? You know, what about the people that are in their 45, 49-year-old kind of age group that are recently divorced, who've never, you know, thought much about condoms except for protection, except for contraception, and now we need to talk to them about using them for protection of STIs and how important it is to regularly be checked. Thanks, Katie. Very complex, the work of prevention. And this is really true, very much a part of my heart and the work that we're doing here at Warragee Medical Centre now. So preventing mental illness, we have to include this in all assessments. We are not only working to prevent chronic physical illnesses, we are trying to prevent chronic mental illnesses. And this starts really early. There is often young people 11 and 12 developing anxiety, and young Indigenous people that are not even 10 yet that have been exposed to different substances and anxieties and trauma. So every person that comes into the consultant's room and sits across from us, we really need to look for indicators of mental illness. And still there is a stigma around it, and people need gentle probing to actually uncover some of this. If you lose concentration with your listening somewhere here, you'll miss the spot. But it's all about how their relationships are going. What about their sleeping patterns? Are they enjoying life? Are they feeling worried? Are they lonely? Are they using any substances at all, including alcohol and nicotine? But what about cannabis and cocaine and amphetamines? Generally, when you ask these specific questions, people will be honest with you. Have they been exposed to domestic or workplace violence? Have they ever had thoughts of self-harm or suicide? And we need to distinguish this here, because self-harm nowadays is seen as, you know, the people that tend to cut themselves, whereas suicide is that finality, and we need to explore this. And sometimes it's uncomfortable to do, but the more you ask about it, the more comfortable you'll find that you are, and how you manage the situation when you ask somebody, have they ever thought of suicide, and they tell you yes. So, you know, there's a great course that Origin Health do all around Australia, and it's Mental Health First Aid, a 2-day course that everyone should go and do, and it really helps you to be able to distinguish some of these early indicators. So if I were doing a 45 to 49-year-old health assessment, I would include these mental illness indicators of mental illness questions. And if things were looking quite serious, I might engage in the DAS-21, which is a little more specific than the K10, but I normally would not go a lot further unless that this was a very urgent need. And what I would do is ask the person to come back in 2 weeks' time for a dedicated mental health appointment. So it's not about trying to cram it all in together, but if we do identify that there are early indicators, then we need to bring them back fairly quickly and have a much more dedicated look at that. Thanks, Kate. And another part of the landscape, this is the Illawarra here, the beautiful, beautiful escarpment. I drive past this most days. It's just absolutely gorgeous and green in this picture. So we're going to chat now about nurse clinics. Thanks, Katie. Sometimes we get a bit confused around nurse clinics, and often it's because we call them nurse-led clinics, and doctors sometimes think that that means that they're not a part of that. They're not going to be a part of the clinic at all, whereas indeed they are still as important as what they always have been in the work we do in primary health care. So these nurse clinics are an alternate organisation of appointments, just a different way of scheduling them. The consultations are coordinated by the GP nurse. They're collaborative practice models, which means yes, the GP is included. They're always a part of the clinics that we run here at Warringah Medical Centre. It's delivering person-centred care. When we have nurses, you know, that are actually organising and coordinating the care, the evidence shows us, and this is evidence gathered in research, that people are much more satisfied with their care. They feel that they are really and truly being cared for, and their health outcomes improve. So delivering person-centred care is great. The other benefit is, of course, it gets to empower nurses to work to their full potential. We often hear in general practice and in the hospital system that nurses are constrained. They feel there's far much more that they can do. So organising things through nurse clinics gives us that opportunity as well. And it really supports our GPs and our doctors in providing quality person-centred care as well. So often what happens in the clinic that I run here at Warringah is the GP will come into my consult room and we'll talk about what our priorities of the consultation have been, rather than the person going from me to the waiting room and then to the doctor. So supporting the GPs in quality person-centred care, and you often need to use that kind of analogy to help get your clinic up and running. Thanks, Katie. The benefits of the nurse clinics, and we've talked a bit about it, so it's increased engagement and satisfaction, improved health outcomes, it enhances teamwork. It's a rare thing in my experience in general practice that we do case conferencing. However, here, you know, in Warringah, we're regularly now case conferencing because we've got the whole team together. We've got everybody that wants to talk to each other about the person, bringing the person in on the case conference and their families as well. Whereas in the past we would have just been having all these individual conversations in the corridor. And it does foster job satisfaction. I love my job every single day. It's hard work, and it's really emotionally draining, but I'm very satisfied at the end of the day with the work we've done. And it also contributes significantly to the business model. Nurse clinics are not about reducing a practice income, they're about maximising practice income, and we will have a little look at some income in a minute. And it also, if you start thinking around clinics, it stimulates innovative thinking, opens your mind up to differences and alternatives that, you know, previously we kind of sit in our boxes and don't think much about what else we could do. But once we start looking at nurse clinics, it does open up our ideas. Thanks, Katie. Always, nurse clinics are always population health based. They have to be population health based because we need the data to support our funding applications. So we need to work out what the priority population is in the area that you're working. No sense if you've got an established patient base that are mostly over 65, no sense trying to get a youth clinic up and running for, you know, a handful of people. And this is when we come in and we use our databases to establish just what is the extent of the need. So we can use, you know, tools that are in best practice or other program software. We can use PenCat, lots of different database tools at the moment. And you know what, often, well, I know for me, when I started actually using PenCat and looking at the database, I was so overwhelmed. It was just thousands and thousands of people, and it was like, I'm never going to be able to see all of these people. How am I ever going to work all of this out? And then we decided we needed to refine our searches into manageable numbers by becoming much more specific, putting in the priority age groups, adding in the risk factors such as blood pressure, lipids, fasting glucose, family history. We could look at those that had, you know, results that were out of range, but we could also identify the people who had never had any of those measures. We used MBS item numbers as well. Part of our priority was mental illness, so we looked at those with mental health care plans. Always the disadvantaged groups. We've got a high Indigenous area, high socio-economic burden, so they come into play. We very specifically went in after specific, you know, certain medications, the one that increased the cardiometabolic risk in people with mental illness, and we also looked at those that had already had care plans. So this really brought our numbers down into the hundreds, which was much, much more manageable and easier to look at, and it made it more doable for us. So refine, have a look at the extent of the need, but then refine it down into numbers that you're going to be able to work with. Thanks, Katie. So the action plan, we've always got to have a plan if we're going to start on a new process. And first and foremost, we identify that priority population, and then we need to look at the literature. And it's easy for me because I work teaching undergrad medicine and nursing at uni, and I'm just in my very last unit of my master's. So I have access to a lot of databases, but you could try, sometimes your primary health network actually has researchers that can do some of this work for you. And everybody can access the Australian Institute of Health and Welfare. Their website, they turn numbers into extremely useful information. I find reading their reports is actually enjoyable, it's not dry. So it's a great starting place. Collaborate with the experts, and we know that APNA is supporting a lot of the work of primary health nurses, and so they would be one organisation that we could go to and say, I'm thinking about a nurse clinic, what could you do to help me? In South Australia, it's the South Australian Sexual Health Awareness Group, and you'll find that in the sexual health clinics, they are actually nurse clinic models. They've been doing it for years. It was just never identified as that. The same as ASHM. You know, these are great organisations to talk with, and if they don't know the answer to your questions, they will find somebody that will be able to answer it for you. So collaborating with the experts right there at the beginning is really important. You need to develop the business model. You need to be able to show how this is going to be sustainable. So you need to have a good hard think about that. You need to also have a 3-monthly work plan. It's no sense I started off with a 12-month work plan and it was just out the door straight away. So, you know, keeping it manageable, but you need a plan that step by step you can tick off every week and know that you're making progress. You also need an agreed appointment schedule. So if you're wanting to do preventative work, it's going to be a minimum of 30 to 60 minutes. And in the early days, you might want to set everybody at 60 minutes for an appointment just to make sure that you're covering all bases and you're able to look at your research and get your time management skills up. The other part about time that's really important is negotiating the protected time. Sorry, just had someone come in my room. Negotiate the protected time. You're going to need non-clinical time to be able to continue to look at your statistics and see how you're going. So having a bit of time, an hour or so a week that's put aside, even an hour a fortnight, is really important. And for me, you know, when I started this, I'm like, yep, I know what I'm doing and I can just get in here and it's all going to work out. And it didn't. And in the first 4 weeks of running our clinic, I was really, really disappointed with myself. I thought that, you know, I was failing everything, and, you know, it set me back a few weeks until I found a bit of mojo again and got up and running. So don't go in with unrealistic expectations. Just remember, this is a new thing, a new design, a new way of working that you're doing, so give yourself a break and a pat on the back for doing that. Thanks, Katie. And then we need the important steering committee. It might be, you might call it a project committee, a steering committee, an evaluation committee. The name's not important, but it is important to have this group. It's not just a one-person job to have a nurse clinic. You need a few different minds to work out the best way and help solve some of the barriers that you'll come up against. The first instance, it must be an experienced, qualified and passionate nurse. if you haven't got the experience, qualifications and passion, then it is not likely that this will take off readily and be a sustainable model. So by qualified, I don't mean that everybody has to have a master's. If you're, if you're really interested in wound care, being qualified in wound care is that you've undertaken some education in that area, and that's what's important. So we also need a governance framework, and the first part of our frameworks of governance for nursing are the Nursing and Midwifery Board of Australia. That's where we have the Code of Ethics, the professional boundary guidelines, all our competency standards, which are now called professional standard frameworks as well. There's about 8 different sets of codes and guidelines here for us, and we need to work within these boundaries that are very specifically nursing. And I find it really interesting in general practice where often the NMBA codes and guidelines can't be found anywhere, yet that is so important around governance. And the other book that's a good one to have a look at, which takes in some of the governance, is the Nurse Clinics in Australian General Practice. So that one is held with APNA currently. It will undergo a review soon enough, but it's always worthwhile having a look at their framework. So we need a defined referral pathway as well, and this speaks back to the NMBA codes and guidelines, because there is a nursing decision flow chart that is really important for every nurse working in general practice and primary healthcare to look at. This is a one-page document, and it clearly outlines when the nurse needs to refer the patient on or get additional help. If you are not looking at this document, you may find yourself in a sticky situation where you'll end up in front of a court who will, of course, be assessing you against the NMBA codes and guidelines. So they're not going to be assessing you about what was the workplace culture. It is about what are the rules and regulations for nursing. We also need to have our outcome measures, and the Australian Commission on Safety and Quality in Healthcare is just fabulous for this. It's a really large document, but there are so many different ideas on what you can measure and what those outcome measures might mean to your patients and to your teamwork. So really important document to have a look at. And the final part on that is that you need the implementation strategy, and you need a group of people to help you with that, because you might go in and think this is what I'm going to do, but if you had your practice manager and your GP and maybe some reception staff or other nurses along, then you would find that your implementation strategy is much more likely to survive. Thanks, Katie. So measuring success, this is the most important part of your clinic. If you're going to run a nurse clinic, particularly around prevention, you need to measure the outcomes. So everybody needs to know how important it is for evaluation. We need to put it as a high priority and not let it slip under the covers or under the rug where nobody thinks about it. You need a dedicated person that has got the time to be collecting your data for you. You need to keep re-looking at your data collection methods. We keep refining ours down because we find some of the information we decided to collect in the beginning is actually of no use to us. It's not giving us any new information. So we've just, reduced some of the columns that we're doing. You need to always have that plan when it is that you're going to measure and review what your key performance indicators are, and have a commitment to do that. and quantify your improvement percentage. Yeah. So often what we do is say, look, we want 100% of people to have this or that done, or their allergies, let's say, for instance. Whereas the reality is, if you're at 50%, an improvement is if you get to 60%. So rather than having an absolute number to achieve, how about measuring the improvement percentage each month to get you where you want to go? A much more positive way of looking at things. And we also need to have that cyclical approach. And the Improvement Foundation have always been great, strong supporters and help us a lot to do the plan, do, study, act cycle. So Improvement Foundation has got the templates, they've got the information, they've got everything that we need to actually have this cyclical approach. So it's not right at the end of the month, it's like, oh, we've got to do evaluation. What the PDSA helps us to do is have a continuous cycle across the whole time that we're working, that we can add to each week, each day even. So good to chat with the Improvement Foundation about your evaluation as well. And think about including patient empowerment in your ethics approval. Really have a good, in your data collection, have a good long think about this, because this is the side that shows some of the improved outcomes from nurse clinics. But just beware, if you are working with people with mental illness or young people, there are some vulnerable populations that you would need ethics approval for to actually be undertaking interviews. But there is a really good tool out there called the PEST tool, and it's already been designed and validated. I think it was from ANU. So there are information and sources out there for you to use. You don't have to develop your own. Thanks, Katie. Oh, and here we are. It's been a rough week, but hey, I made it. How about you? I think this nearly every day. At the end of the day, we kind of gather in the tea room and we have a bit of a moan and groan and a whinge about how busy our day's been, and then we just start laughing and laughing about all the difficulties that we've faced. And it is really, really important that you look after yourself when you're running a project, yeah? Because if you're doing something where you keep coming up against barriers, you're going to need some way of debriefing and being able to unload. And we're just lucky here at Warragee that we get to do that together before we go home. So the Skip Into Life Nurse Clinic is the clinic, the enhanced nurse clinic that we're running here at Warragee 2 days a week. It started as a preventive clinic for people with mental illness, and yes, it is still there as a preventive clinic, but very quickly we realised that it needed to be holistic. So what that means is, if the person on the day, if it's their mental illness that is dominating their health, then that's what I get to work with on that day. I can't intrude the physical if I'm trying to look at a whole person and help. We have to work together with whatever we need to do. So what everybody gets when we actually come to this clinic is that comprehensive bio, psycho, socio-cultural assessment, even if it takes a few appointments to get there, but that's what we're aiming for. And at the end, when people really and truly feel that they've been heard and that they're cared for, the way that they respond, they reduce their agitation, they make appointments to come back and see you just to tell you how well they're going. It's just a marvellous turnaround in implementing person-centred care for this very disadvantaged group, people with mental illness, and a lot of them are very traumatised from the healthcare system that they've had to that they've been a part of for most of their lives. So we do engage, educate and empower people so that they can enable themselves in what it is they want to do. We give the person a voice in their care, we encourage them and we teach them how to share in decisions. It is ongoing care. Sometimes when I meet a person I might be seeing them every single week or ringing them up you know, once a week and seeing them every fortnight, and then bringing them back 3 months later, and we integrate the team. As I said before, we're actually doing case conferences, which is really good, but we're always collaborating and we're bringing in as many people as we can to be a part of that integration. Thanks, Katie. Just a little bit, you know, I've always got to hold my breath and have a moment's silence with this. This was a creative reflection of the first few months that I'd worked in the Skip Into Life clinic, and I'm a general practice nurse. I'm not a credentialed mental health worker. But these were the presentations that were before me. The person up there in the left top corner that always put on that good outward persona, but on the inside they were just screaming to get out. The man with the glasses crying who sat and told me for 90 minutes of the horrendous abuse that he and his 5 siblings, when they were between the ages of 3 and 8 in institutions, and then how the Royal Commission had opened all the wounds up again and belittled them by giving them money to say, well, you know, this is the way that we can say sorry. The people that are so fractured from the healthcare system. It's really, really hard and emotionally trying work. But here in the middle, when I is replaced by we, even illness becomes wellness. And the cardiac, the heart down the bottom, is just to remind us that people with mental illness die 20 years earlier than those that don't, and it's not through suicide, it's actually through cardiovascular disease. Thanks, Katie. So examples of some nurse clinics, and here we've got the beautiful Jodie from Melbourne who's doing wound care, the fabulous Bega Valley team down south of me that are doing youth health, but you could think about vaccination, women's or men's health, it could be well babies, lifestyle coaching, Osgris, cardiovascular risk, Indigenous health, weight loss, 45-year-old health assessments. Indeed, this is at your fingertips. However your imagination can go, wherever it goes, you could bring in a nurse clinic. Thanks, Katie. Our next one looks a little bit more at some traditional styles. We could go, you know, in preventive sexual health, bloodborne viruses, substance use. We could look at health literacy, patient education, medication awareness, all these different kinds of chronic disease management. And what about palliation and the end of life care? So the top picture here is Carolyn, who's actually running a healthy aging clinic in Ballarat. Hers is all about early diagnosis of dementia, and down here in the bottom picture, that's us here at Warringah Medical Centre. That's all my guys that are on my steering committee and data collectors. I'm surrounded by wonderful women. Thanks, Katie. We're moving now over to funding, and we're nearly through what we've been doing. Just like the look of this picture, it is not a local picture, but see how the concept is that there's a little pool that fills, that flows into the next pool, into the next bigger one, and finally out into the big one. And that's to open up the way we think about funding. We get so stuck on the MBS, but indeed if we want to run an innovative nurse clinic, then we want to have innovation funding for it as well. So we'll have a bit of a look at the funding that comes. Thanks, Katie. First and foremost, remember, as nurses, the PNIP, there is $25,000 per full-time GP for an RN to work 12.6 hours. It's exactly 50% of that for an EN to work 12.6 hours a week, plus loading when you're outside of metropolitan areas. So never forget, as a nurse in general practice, you are already contributing significantly to the funding model. We also have the other practice incentive payments, which are one of those little pools feeding into the big one, but most of you will probably know that the practice incentive program is coming under a major review and restructure, and we're going to lose a lot of our separate incentive payments, and they'll all be brought into one quality payment. There's also facility income. It's another one of those pools. Do you rent to pathology? Do you have specialist rent rooms, allied health people? Also innovation funding, and this is where we got some money to help us with SKIP. It was through the national organisation of APNA, the Primary Healthcare Nurses Association, who are administrating on the Department of Health side to get these clinics up and running, 11 sites across Australia, to have a look at the models, look at what's sustainable, and look at how we can provide quality patient care as well as reduce overheads with the budget. So always keeping your eye out for what's happening in different organisations, and please knock on the door of your primary health network and keep knocking. You might not get through that door at first, but just keep on knocking, because they all have flexible funding and innovation funding. Thanks, Katie. I know this slide just looks full on. It's very different when we animate it one by one, but it's to show you just how much there is in the MBS to support preventive health care in general practice. We've got the 707 in the top middle, and that's our gold standard. That's our 60-minute health assessment, and that's one that I really, really love. To the left, we've got the Indigenous health assessment, and we know once we've built a 715, that then gives us 10 episodes in a year of 10987s, and they're funded appointments for the person to see the nurse, just like the 10997s that we get off our care plans. And I know some of you will be saying that you can't use a care plan in prevention, but we are going to have a look at a couple of rules that help us to see there are sometimes areas that we can actually use our care plans in prevention. Then we've got the 705, which is the 45-year-old health assessment, the 45-minute one, the 703, which is down at 30 minutes, over on the right the 701, which is much, even though a few of them are actually done, but less than 30 minutes is difficult to actually work with and listen to a person. You can see there in the middle right as well is the 2700 series. That's our mental health care plans and consultations. This is a big part of our funding model. We've got down towards the bottom the care plan reviews. We've got the standard GP consults as 23s and 36s. Starting from the bottom right, we've got, you know, the Dopplers, then the Spiro. We've got our current cycles of care. ECG on the left is the 11700, and over on the far left, and they're the consult item numbers for GPs that are doing pap smears for women that have, it's been about 4 or more years since they've actually had a pap smear, so they're under screen. So the blue ones here are really those that are our core funding, our, you know, primary funding models and the way that we connect with people. In the green, that's all of the ones that are follow-up assessments, and the 4 that are in the yellow print in the numbers, they are the only ones on this page that are GP specific. The rest of them, the nurse is a valid contributor to those actual assessments. It is only just the 4. So sometimes we think that, you know, the nurses, since we lost our item numbers, aren't able to participate, but we can. Thanks, Katie. And now we've got just some rules and regulations, and I suggest that everybody go to the Department of Health webpage and click then put in the search CDM Q&A, and you're going to find an amazing amount of information. So it clearly says that the eligibility for CDM is essentially a matter for the GP to determine using their clinical judgment and taking into account a number of complex factors. The GP may consider the circumstances require the preparation of a care plan because of such things as non-compliance, inability to self-manage, or functional disabilities. You think about this, we see that a lot in our area. People with one or more conditions may be unable to self-manage or comply with treatment orders, be functionally disabled. These people might in some instances benefit. Next slide please, Katie. And so this is giving us the guidelines on where we can use care planning in prevention. So CDM for medical conditions may be beneficial in some circumstances, such as substance use, obesity, hypertension, dyslipidemia, impaired fasting glucose, or impaired glucose tolerance. And this is direct from the Department of Health website. This is not me adding these diagnoses in. And I know here at Warragee one of the rules that we work by is that we, if we're looking at a care plan in a prevention mode for somebody with some of these conditions, we always want there to be a minimum of 2 conditions, not just one. And we also look and put in our notes what it is that's the functional disability or what it is that's the barrier to self-care, so that we're very clear about why it is that we're hoping that a team of providers will be able to help this person from progressing into long-term illnesses. So the Department of Health recognises that conditions such as these can occur across a wide spectrum of severity, including people with complex health needs and severe disabilities. So it's really important for everybody to go to the Department of Health webpage, type in the search CDM Q&A and bring it up and have a look. Often 2 come up in the search, and you go to the one that was the 28th of April 2014 updated, and you'll see just heaps of facts pages to link on. But the key message from the department is that the need for these services must be clearly identified in the patient's file and in their care plan. So that's really important. We need it in the clinical file, but we need to justify it in the care plan. And thank you everybody for listening. That's brought us to the end of the webinar today. Thanks so much to the Government of South Australia and the SA Health for having this wonderful series on prevention of chronic illness. And thanks so much to the Improvement Foundation for all their hard work in spreading the word around. Thanks, guys. Bye.
Roz, just before you leave, I'm just going to see if anybody, I don't have any questions in the chat pane, but I'm just going to give everyone a chance to either ask a question or raise their hand.
No worries.
There is a comment, thanks Roz, from one of the attendees who had to leave early, so that was a bit of a shame. Whilst we're waiting to see if anyone's got any questions, thank you so much, Roz, in sharing all that information. That was terrific in that 1 hour to have learned so much about nurse clinics and prevention, just demonstrating how it can work and inspiring people to go off and hopefully start their own nurse clinic and encourage others to do the same.
Oh, thank you.
I did just want to mention, I believe when you were talking about the PES tool, so just to let people know, that is the Patient Enablement and Satisfaction Survey, is what it stands for. And Ross, am I right in thinking that's available on the APNA website?
I'm not 100% sure that it's APNA one, but I've got one at home, Katie, I'll send to you if you like.
Terrific. And if anyone is interested in having a look at that survey, please email me at the Improvement Foundation and I can share that survey with you.
And the other one, Katie, too, remember we did a list of references around prevention. I might email that one to you as well.
Fantastic. Okay, I'm just going to unmute Rhea, who has got a question, I believe. Rhea,
yes, I'm here. I'm sorry, I was late joining. I just had trouble with our security at this end, but I finally did join. But I was just wondering if the webinar's available afterwards to access.
Thanks for your question, Rhea. Absolutely. Yeah, we record all of the sessions. So this particular webinar, plus the 4 that have preceded it, are all available. At present, I believe they're going to be available on the SA Health website and Country Health SA websites. But I will find out whether or not we can make it available on QI Connect, which is the Improvement Foundation website as well. So a big thank you to all of you for attending today's final webinar, and a really big thank you to Roz. Terrific presentation as always. And again, I'd like to acknowledge SA Health. So thanks everyone, and have a great afternoon.